So I won't bore too much. I'll just speak on the therapeutic interventions in liver disorders. You see, the diet in liver disease, we have three main domains. The first is treating specific diseases like galactosemia, Thyrosinemia, Wilson's disease, glycogen storage disease. The second aspect of liver disease is ascites, what to do in that scenario, encephalopathy, what to do there, cholestasis, how do we treat? And the third scenario is where you have viral hepatitis. And as you know, in India, we have a lot of taboos and stigmas that are associated to the same. So when we look at nutritional intervention in liver disease, you have 3-4 areas to focus on. That means ingestion. First thing is ingestion. Are you giving something that is going to be toxic? Are you giving a toxic byproduct? Like galactosemia, if you give milk, it becomes a toxin. In Thyrosinemia, it becomes a toxin. Or are you wanting to target the end product, like glycogen storage disease, where the glucose is everything? Or are you going to give a supporting nutrition based on your intervention, like medium chain triglycerides in cholestasis, copper restriction in Wilson's disease, salt restriction in ascites, and branch chain amino acid in hepatic encephalopathy. So based on how and when these children present to you, your dietary interventions are going to differ. So that means a neonate, you will have to stop the breast milk because he can have galactosemia. But Wilson's disease, since it presents in childhood, then the intervention becomes different. Similarly, for various disorders, the timing of intervention and the quality of food that you are going to give is all going to change based on when the disease has started during the childhood. Now, first we look at specific disorders. So galactosemia, and I've been trying to educate a lot of people on this because this is one common condition which the pediatrician picks up, but a general physician might not be able to pick up. So in galactosemia, as you know, you have to give a lactose-free formulation. So it should not convert to galactose. So lactose is a rich source of galactose, and basically you have 3 choices here. One is you can give a non-lactose casein-based formula. A lot of people make this mistake. We are not supposed to give the casein because the casein contains about 17 milligrams of galactose per 100 ml. So casein is not to be given. In India, we promote soy-based formula. So soy-based formula is not containing galactose or very minimal galactose, but there's a problem that in children less than 6 months, soy is not to be promoted. And this is not me saying it, it is by the American Academy of Pediatrics, who says that soy is not to be given in less than 6 months. So what are we left with? We're left with a hydrolyzed formula. Now, hydrolyzed formula in India is very expensive, and the galactose contained there is negligible amount. So ideally speaking, hydrolyzed formula, but since we deal with a poor setup, then we may give a soy-based formula. Now, a lot of people ask me that should I restrict galactose in these children and adults, because these are the children who will grow into adults with an almost normal outcome. You see, there is a concept that fruits and vegetables are not to be given because they contain a lot of galactose. But there are 2 points here. The endogenous galactose production is about 1 gram per day. It is way higher than what fruit and vegetables are going to contribute. So that will be 1 drop in a big ocean. So don't stop fruits and vegetables. Secondly, the fruits and vegetables contain bound galactose. That means this galactose is not going to actually cause a lot of toxic problems. It is the free galactose that is important. And milk products contain a lot of free galactose. So the fruits and vegetables, by and large, can be given to those children who are having galactosemia. This is a study which looked at a few patients who were consuming a lot of fruits and vegetables and what happened to their galactitol level. They found no change, nothing happens to them. So there is no difference with or without exogenous galactose. And they say to generate 600 mg of galactose to produce toxic levels, you must eat 7 kilos of apples, 2 kilos of potatoes, and 12 kilos of peas to generate this amount of galactose, which can be toxic to your body. So basically, fruits and vegetables can be given. What are the long-term effects of consuming dietary galactose? Well, dietary galactose, those who have been permitted versus those who have been restricted in adults, they have said that there is no new liver disease and there are no new cataracts that occur. So dietary galactose in the form of vegetables and fruits are allowed, but obviously you cannot take milk. Now, this is a paper that we wrote up for Indian Pediatrics way back in 2015, where we looked at galactosemia, and most of our children presented as cholestasis. And you see the median age at which they presented was 10 days. That means from the day they have consumed breast milk, in 10 days' time, they have become symptomatic. That is how fast the disease is going to progress. Now, what happened to these children? Now, here I will tell you a very short story, and please bear with me. But Dr. Rachana, who's my good friend, would remember back in our residency time, we used to work very hard on these galactosemia patients, and we used to outsource our Galliput levels to a Lal pathology lab. And this Lal pathology lab, PLE madam, was just outside our Madhav Ashram, if you remember, small lab. And the person who used to collect the samples, he used to test them, and he used to tell them on the phone, the children, start consuming milk, stop milk. And this is something he did at his own risk. And two children who were confirmed galactosemia, he had given us normal galactose 1-phosphate uridyl transferase levels. He told them to start milk, and those two children came back and died. This is the two deaths that I've highlighted there. Very unfortunate. We got hold of that guy, brought him to the ward, made him pay for the mistake that he had committed, but it was too late. The children died. Finally, we found out that this was actually a fake lab that was running just outside SGPGIMS. Yeah. So this was a fake lab, and we had complained to the police regarding this. So all I'm saying is, in galactosemia, if you stop the lactose, you are going to come with a very good outcome. So if you see, our overall survival was 87%. That's a very good outcome. A few of them have cataract, which is well taken care of. Some amount of developmental delay is there, but in general, you can salvage the child. This is the galactosemia family, who I always show in all my slides. This is a mother and a father who lost 3 children before they could diagnose galactosemia in their child. And look at this boy, he's 6 years of age with perfectly normal writing and mentation. And this is that little girl also who has grown up now. And this father always says, let us not lose any more children. And he's one person who helps me promote this message all across India. The next disease I'm going to talk to you about is Wilson's disease. You have to understand, in Wilson's disease, we have to make a compromise. Okay? And the compromise is such that we have to allow some amount of copper to come into our body for our regular body function. At the same time, we must not allow a lot of copper to deposit into the body. So if you look at the diet, it contains about 5 milligrams of copper, and we excrete about 4 milligrams of copper. So what happens is 1 milligram goes into our body and goes into various kinds of circulation, and this is transferred from blood to the musculoskeletal to the liver and excreted in the bile, and so on and so forth. Now, when we look at dietary copper in Wilson's disease, we usually avoid liver, shellfish, nuts, chocolates, and mushrooms, because this contains a lot of copper in its sources. So the first year of treatment, we usually stop. But in the next subsequent years, we allow at least nuts, chocolates, and mushrooms, but possibly not liver and shellfish, because that contains still a lot of copper. There is a lot of concern as to whether we can use water copper pipes, but the water copper pipes actually now are no more used because copper is very expensive. So you are using actually aluminum pipes, and the water supply should give you only less than 0.1 parts per million of copper. So basically, first year is the most important year. Next year, once the chelation has started taking place, then even the copper that you are eating as ingesting, that will also be taken care of. Now, here is a guideline that we published in 2019, and this is on Wilson's disease. And here there's a small excerpt that we have written about the diet. Please remember that whatever is baked, whatever is shelved, whatever is roasted will contain higher copper than what is cooked or boiling hot. Okay, so all shelved items contain very high copper. But there are some innate products that we use, like red gram, soya bean, lotus stem, all the nuts, some of the masalas. But since you don't consume a lot of high masalas, only very small quantities, it doesn't matter. But the rest of the products contain very low copper. And this is from the National Institute of Nutrition 2017. We compiled all the data that was there for the copper containing products, and we came up with this chart. The third condition I'll talk to you about is Thyrosinemia, and I will not go into the pathophysiology of the same, but here there is a small enzyme that is affected, and based on that enzyme, that is fumaroacetyl acetate hydrolase, there's a lot of back pressure, and a lot of phenylalanine and tyrosine are going to get accumulated, and this will lead to various kinds of hepatoneurotoxicity. Now, nitrosanal, which is the drug, is the mainstay of therapy, but there's a role of diet here. On one hand, you see it's all about balancing. On one hand, you have body growth, which requires tyrosine and phenylalanine. At the same time, increase in tyrosine and phenylalanine will give rise to hepatotoxicity. So what does nitrosanol do? Nitrosanol takes care of this increase in tyrosine and phenylalanine. And what does the diet do? In diet, we try and decrease the amount of tyrosine and phenylalanine entry into the body. So normally what happens is, and these formulae are now available in India. So in an acute crisis, you give a tyrosine-free, phenylalanine-free diet. You stop the breastfeed. Then you, once the disease is settling down, you gradually introduce breast milk, because that is very, very important for the children. And then you give a tyrosine and a phenylalanine restricted diet, and you try and maintain the plasma tyrosine and phenylalanine to some levels which are 200 to 500 micromoles per liter. The problem with Thyrosinemia in India is the conformation. We don't have ready conformation, so this is a difficult disease to treat. So dietary therapy alone is not effective, but dietary therapy alone can give rise to improvement in the renal tubular function, but it will not make any change to the liver disease. The fourth condition I'll talk to you about is hereditary fructose intolerance. Here, fructose is not converted, and thereby the glucose is not generated enough, and it causes hypoglycemia. What do we do? What happens in this? In this, if you give a fructose load, then you have GI symptoms, you have hepatic symptoms, and sometimes even psychiatric and seizures in children. So what is allowed is basically glucose powder. You can allow milk, because milk is glucose and galactose. You can allow legumes, meat, and all other products, but you are not allowed all the sweet products, that is fruits, juices, table sugar, honey, jaggery, some of the vegetables which contain high amount of fructose, and all the shelved products. The fifth condition is glycogen storage disorder, and here, for liver point of view, we have three important ones, which is type 4, type 1, and type 3. Type 4, let's not talk about it too much, because type 4 does not actually survive. So what is important to us is type 1 and type 3. Type 1 has profound hypoglycemia. Type 3 has slightly lesser hypoglycemia, but it can be a very problematic hypoglycemia. Now, you all know that cornstarch therapy is the most important cornerstone for dietary management in glycogen storage disease. And everybody, and a lot of people ask me, why cornstarch? Why not rice starch? Why not wheat starch? And why not potato starch? You see, that's because cornstarch has a very unique structure of the amylose and the amylopectin, where the ratio of the alpha 1,4 and the alpha 1,6 bonds are 20:1. The other starches or the other carbohydrates don't have. Now, we give cornstarch because it breaks up little by little, and gives you a continuous and a sustained supply of glucose from the gut to the body. So the ratio of alpha 1 to alpha 6 is the most optimum in cornstarch, and that's why it becomes the cornerstone of therapy. So what happens is the complex starches have a low glycemic index. So you have a slow digestion and sustained glucose release. This you can give cornstarch by a continuous nasogastric drip in those children, especially type 1, who are very symptomatic. You can give it throughout the day or in the night time. And those who are intermittently feeding orally, you need to give early night and early morning, and maybe a little bit throughout the day. You have to give cornstarch. The rest of the time, the children can eat their normal food. And the dose of cornstarch you need to give is 1.75 to 2.5 grams per kg per dose. Too much of cornstarch ends up with a lot of obesity, so we have to carefully titrate cornstarch. The other things that we modify regarding diet in GSD1 is that we have to restrict the sucrose. We have to understand that the final pathway, which is glucose, is not being formed. So this sugar that you are giving will also give load and will not be able to convert to glucose. Hence, we have to restrict sucrose, we have to restrict lactose, and the cornstarch is to be mixed with plain water only. If you cook the cornstarch, if you bake the cornstarch, if you boil the cornstarch, then it loses its potency to give you that amount of glucose which is sustained. In type 3, you don't have this restriction of sugar or milk, but what is important in type 3 is that there is an increased muscle breakdown for glucogenesis, and hence we need to supplement that by giving around 3 grams per kg of protein. Next, we look at chronic liver diseases. In chronic liver diseases, what is important is giving a very balanced, again, it's a weighing machine here, and you need to give a balanced this thing of branch chain amino acids and aromatic amino acids. The branch chain amino acids are the good amino acids that are important for chronic liver disease, that is leucine, isoleucine, and valine. The aromatic amino acids will be the ones that cause false neurotransmitters, which cross the blood-brain barrier and give rise to hepatic encephalopathy. So one of the hypotheses of hepatic encephalopathy is giving a lot of aromatic amino acids. So you're going to try and shift your focus of management of protein with the branch chain amino acids. Now, meta-analysis in adults we don't have in children, but meta-analysis in adults have shown that there's a modest improvement in early hepatic encephalopathy when you give good amount of branch chain amino acids, but there is no effect on the mortality. And the American Association of Study of Liver Disease Guideline, they recommend that if a patient is not responding to the standard therapy of overt encephalopathy, hepatic encephalopathy, he may be switched on in refractory cases to branch chain amino acid. And this branch chain amino acid is basically available in sachets and powders. And this you mix it with the diet, and the dose is 0.25 to 0.5 grams per kg per day in children. Now, the protein restriction in hepatic encephalopathy is a very controversial area. On one hand, the muscle mass is being lost, so you need protein. So sarcopenia is a situation where the muscle is being lost. You call it asthenia also. And on the same time, if you give a lot of protein, it may result in hepatic encephalopathy because the liver is being bypassed and all your ammonia is basically going to come and going to bypass the liver, go from the muscle and directly into the brain. So you need to have a fine balance here. So the AFLD, that means the American Association of Study of Liver Disease, recommendation is that when the patient is having overt and acute encephalopathy, at that point of time, you come down on the protein to 0.5 milligrams per kg per day. But once this encephalopathy is gone, you should go back to the normal protein intake, which is 1.2 to 1.5 grams per kg per day. And this needs to be sustained because these patients and children are going to be sarcopenia. Now, what is the choice of protein? There is a lot of controversy on this as well. But overall, people agree that vegetable or dairy-based protein are the safest proteins because they facilitate ammonia disposal and they're very low in sulfated amino acids. Animal proteins, that is meat, contain a lot of sulfated amino acids, and these are precursors of mercaptans and indoles that again precipitate encephalopathy. You must give a high fiber, and there should be a good, rich source of short-chain fatty acids as well. What happens in ascites? So here is a problem because ascites is precipitated by the sodium, so we are going to ask for low sodium intake. But remember, low sodium intake decreases the palatability of any food item. So that means you're going to compromise on the calories and proteins. So what do we do? Again, it's a fine balance. If you give stringent salt intake, you're going to go into acute hyponatremic syndrome. You're going to go into hyponatremic encephalopathy, and there are chances it may also lead to hepatorenal syndrome and some other issues. If you give unrestricted salt, it will lead to ascites, and although it will make the food very palatable. So how do we balance this? You see, 1 gram of table salt contains 17 milliequivalents of sodium. The restriction of sodium in infants is restricted to 1 to 2 milliequivalents per kg per day, and in adolescents, it's 1 to 2 grams per day. The earlier restriction to 21 millimoles per day has been discarded because it is not palatable at all. So right now, what the adult guidelines at least say is that we should restrict to only 88 millimoles per day. That means 2 grams of salt per day. These are some of the items that contain a lot of sodium. So you're not going to ask them to take sauces, bakery products, all your salted mixtures, and the rest of the other items, which are the regular vegetables, the regular meat, and everything else, will contain a decent amount of sodium, which is not going to be alarmingly high and cause problems. There are problems with the compliance when you ask for a low sodium diet, and only 10 to 15% of cirrhotics, their ascites can be managed on a low sodium diet. The rest of them will require diuretics. And if a patient is increasing the ascites, despite telling you that he is compliant to the diet, then what you do is that you ask for the 24-hour urine sodium. And if it is more than 78 millimoles per day, then that patient is lying, he's eating salt. The poor compliance, and you need to check there. And if you have a non-mobilizing ascites, but you have a spot urinary to potassium ratio, and you find that less than 1, that means again, then this patient is having a poor compliance. So these are some bedside tests that we do to see whether the patient is telling the truth or not. Now, regarding neonatal cholestasis, the medium chain triglycerides in neonatal cholestasis, you see what you eat normally, the dietary fat, 90% and more is long chain triglycerides. These are required to be dissolved into our circulation with the help of bile salts, which form nissen. Now, medium chain triglycerides, fortunately, does not require the participation of bile salts. And bile salts are going to be very little in neonatal cholestasis. So your way to improve the lipid content in your body and make the child get a little fatter or maybe gain some weight is through the medium chain triglycerides, which are directly absorbed. So the C6 to C10 are directly absorbed into the portal circulation, and C12 is absorbed through the chylolymphatics. 1 gram of medium chain triglycerides actually gives very good amount of calories, and that is 8.3 calories. Now, the problems in India is the availability. You have two major availability forms, which is the MCT oil, which and the two products that I have listed here do not give us the exact content of the MCT. They say they contain 100% MCT, but it is not really mentioned anywhere. The other is the MCT powder, and that is widely circulated. And you will find the pure MCT powder containing 70% MCT. The female MCT powder contains only 15%. Then you have MCT-based infant formula, and in India we have Pre-Nan and Lactodase, LBW, and so many other products. We are not going to the commercial part of that, but they all contain very little amount of MCT. So they will say MCT rich, but actually speaking, they only contain 10 to 20% MCT. What is promising is this monogen, which is promoted by Nutricia, and this has come into our country the last 3-4 years. And monogen contains about 85% MCT. So this is very good for those patients who have neonatal cholestasis. But we have to understand that this is a very expensive product, extremely expensive. So we have to make a compromise here. We don't usually give monogen unless we are dealing with a devastating condition. There are some natural dietary items which contain high amount of MCT, which is like coconut oil, which contains 65%. But unfortunately, the edible coconut oil, which is available, and probably Elizabeth Madam can highlight on that, the one that is available in Kerala and the southern parts of India are not really available in other parts of India. Coconut oil has a dual problem. One is, on one hand, it contains 65% MCT. On the other hand, it contains 35% long chain triglycerides, which can cause a little bit of harm in some particular conditions. But the edible coconut oil is not available widely across India. So what happens when we give MCT?
Moinak, sorry to interrupt.
Yes, ma'am.
Can you wrap up, because we
Yes,
have
ma'am.
crossed.
Sure. So this is the last slide I will show, and this is acute viral hepatitis. There are lots of taboos, and it's up to us to break that taboo. You should give proper nutrition during acute viral hepatitis, a wholesome diet, no restrictions, liberal fat and masala eating. So in conclusion, diet in liver disease is all about a compromise. On one hand, we have science, we have therapy, we have morbidity and mortality, which can be reduced based on the diet. At the same time, on the other hand, we have to compromise on cost, palatability, comfort, compromise, and also the quality of life. Thank you very much.